My name is Bretland. I'm a GP from the Bentley area. Most of my work is in aged care and residential aged care. Can I just ask how many of you work in the hospital setting here? And how many of you work in community? Thank you. Okay. Those of you who work in a community setting will already be aware of this, but I'm just going to remind you, general practice and community care is often quite different to hospital care because we see the same individual over a long, long period of time. 10 months, 20 years, 30 years. So we have the luxury of time, which often we don't have in the hospital. Somebody logs into the hospital, you have to fix them, log them out again. Okay? We have the luxury that we can see people over a number of weeks or months or years. And this is where we come back to what Nick was saying, you know, is less more. Yes, there's multifactorial things we want to do to prevent falls, but we don't do them all at once. We do them one at a time. And we'll talk a bit more about that later on. So what I'm going to do today is just try and talk to you about what a GP can do. Okay, these are my stats, and I suppose, you know, why bother? And you all know this. If people fall and fracture their neck or femur, 50% of them will be dead within 1 year. And that's the cruncher at the end of the day. But on a lesser extent, even a fractured forearm from a fall can make somebody unable to live in their own home independently, which they could do up till now. If they're alone and they've got a plaster on, how are they going to shower? How are they going to do the washing up? How are they going to turn the knobs on their own? Simple things like that. UOTs will know that backwards. And I know that there are ways to help. But the point is it needs an intervention. You can't just leave someone to carry on and do it. So that's why we bother. So what can GPs offer? Obviously, not all GPs are the same, and this is our big, both our best aspect and our worst aspect. Care of the elderly and falls prevention is one of my passions, so it's when I get stuck in. So what we look to do is reduce the risk of falls, try and reduce the risk of a fracture if somebody does fall. We can navigate the patient through community resources. And this is one of our prime jobs, and particularly with access to various hospitals, knowing which hospital to send somebody to, how to get there, etc. And the final thing we offer is personalised care, and that comes from knowing the patient. And we have the well-meaning lawyery types in Canberra writing things about making sure your interventions are patient-centred and culturally appropriate and this, that and the other. We know people, we know what we can get away with, and we'll talk a bit about that later. So how do we reduce the risk of falls? I know I'm preaching to the converted here, there is better evidence for the use of exercise in reduction of virtually every illness than there is for any of the pills. Okay? The reason we don't hear about it a lot is that we can't get anyone to sponsor big meetings like this. I did a literature search for the effect of caffeine on falls. Found one paper. There are about 28 papers on the effects of caffeine on bone density because you can sell a product. Okay? So exercise is really, really important. And again, one of the advantages of seeing people over a period of time is you sow the seed and you gradually increase. It's a bit like coaching. So you see the person the first time and say, well, you're not really doing a lot of exercise, are you, Alf? You just sow the seed. Next time, you doing any more walking? No? Well, why don't you just walk around the unit? Just once a week. Next time, oh yeah, make it twice a week. Let's aim for 5 times a week, and you build it up over a period of time. So you've got them exercising, and the next stage is, what about your house? You've got a ramp on your house because you're a bit wobbly on the old pins, not as good as you were when you're 21. And that's the trouble, we still all think we're 21. Those of you in the room who are 21, cherish it. You're going to feel like that for the rest of your time. So we look at personalised care, trying to get people exercising. And then we can involve the physiotherapy department. Most physiotherapists, both public and private, will and can provide exercise and balance classes. These are brilliant. And I try and get people involved in that. You know, it's really good, you know, they go for walks, they balance on these wobble boards and all the rest of it, and it's great. We get the occupational therapists to come and visit their homes. And this is a real eye-opener, and I understand you'll see photographs of this later. Piles of magazines lying around to trip over. Mats with curling edges, just right to trip over. Slippery bathroom floors. So we get the OTs to come round, look at rails, look at toilet seats, make sure people can get up off the toilet and out of the bath without killing themselves, non-slip floors, all sorts of aids. Even I purloined an aid because I'm having trouble getting my marmalade jars open. So, you know, all these sorts of things to help people manage on their own. We can look at dietary advice. We've all seen patients who subsist on a diet of baked beans and tea. So we can look at getting people to see dietitians. We can organise for good meals to be provided through Meals on Wheels or the various other systems that are there. And that's where the GP comes into his own, because we come down to this last piece here, personalised care. Because the GP not only knows the individual, but he knows what's available in the area. And so I know where I work, some of the people that live in the independent living units in a couple of the retirement villages have got a dining room set up that we can arrange for the dining room to deliver food to them. We can also arrange the various hack organisations to deliver Meals on Wheels. We're aware of the options if somebody doesn't like that particular food. Oh, we had Meals on Wheels, but it was disgusting, so we stopped it. What about the dining room? Do you like the dining room? Oh yeah, they're great. Right, let's get them to deliver. So it's a matter of knowing what's going on locally, and the GP is well placed for that. Reducing the chances of fracture, GPs can prescribe all of these medications. The names will all be familiar to you. I'm not going to go into them in detail because you've got other people who are much smarter than me to do that for you later. But we can prescribe these, and we do. Okay? And that's part of what we do when someone comes back or has a fracture, go through their medications, have a look at what they need, have a look at what they're on. And again, this is another issue that Nick touched on and that I'm sure your pharmacist will touch on, deprescribing in the elderly. And there's no doubt that if somebody is on 5 medicines or more, they're going to run into trouble with interactions between those medicines. And the commonest symptom you get of that is dizziness. Okay? So, and it's not just reducing benzodiazepines or antipsychotics. Any medicines can give you these interactions. Older people are very susceptible to anticholinergic effects. So that small dose of a tricyclic antidepressant they've been given for a bit of anxiety and a bit of sleep for the past 30 years may be starting to have an effect on them. Maxolon Stemetil have significant anticholinergic effects, and so you need to be careful about doling those out for somebody who's got a little bit of indigestion. So you need to think about their medicine load. So it's guiding the patients through the resources in the community is really where we come into our own as GPs. I'm going to start with the government-funded ones, and firstly is this brilliant state government-funded Stay on Your Feet system. It's well advertised. Most decent practices will have pamphlets in their waiting rooms so you can hand these out to people. We know where the local Stay on Your Feet setups are and running, and we can refer appropriately to those. Then there's the federally government-funded various sort of thought bubbles of sorted politicians over the past 15 years. Basically, the divisions of general practice were set up at the same time as divisions of surgery and divisions of medicine were set up in the hospitals to support general practice and primary care. They were then superseded, but unfortunately not folded into Medicare locals, which have once again been succeeded, but not folded into primary health networks. So there are some areas where we have all three functioning. And they've been set up in such a way that they apply for contracts that are federally or state funded. And so they don't all provide the same services in the same areas. So the GP will know which of the various organisations is providing a falls prevention service and can refer appropriately. Okay? So that's an important area. Now the other really important area that we can provide, apart from checking medicines, which I've already talked about, and deprescribing, my particular bugbear, I have to say, is statins. I don't know about you guys, but my major problem with frail elderly people is getting calories into them. It's not worrying about whether their cholesterol is below 6. You know, I want some padding and I want some muscle mass. And so I tend to do quite a bit of deep prescribing, but you have to persuade people. Yes, but you know, what if they have a heart attack? Look, sorry, Dad is 96, okay? If he falls, he's got a 50% risk of dying from a fractured neck of femur, okay? A 1% reduction in his chance of a heart attack, it sort of pales into significance beside that, and the pills may make him fall. So you really have to work with that. The other thing that we can do is we can get patients Medicare rebates for private allied health work. And this is a really big breakthrough. It was originally brought in under the enhanced primary care items that I'll talk a bit about later. But what it means is that an individual who has a GP management plan and a team care arrangement can get access to Medicare funding for 5 allied health consults in a calendar year. So that's starting January 1st, finishing December 31st. And they can be split between any number of allied health professionals. And it actually gives you more money towards the cost of that consultation than your private health insurance does. So it's really helpful to get people the help that they need, particularly those that don't have private health insurance and otherwise wouldn't be able to afford it. But there is some red tape to go through, and I'll go through this in a moment. And the last thing, of course, is coordinating the care and making sure that your individual patient, as you see them over many years, is actually doing what you want them to do. Or at least an agreement between the two of you. I have a patient on my books who is a naturopath, and every year we both satisfy our requirements. Every year I sit down in April and I say, now, would you like a flu vaccine? And every year she says, no, thank you. And I say, right, so we document it all and that's done. So, you know, you have to come to terms with your patients and their wishes. So chronic disease management.
Sorry, excuse me. What's PHN that was on the...
Our primary health networks.
Oh, okay.
They're, I may be wrong about this, but I understand there is an issue with using the term primary health networks. Is that right?
I think they've been closed in and now they're primary health alliances.
Primary health alliances.
WAPA.
Yeah, well, primary health alliances. There was an issue at the stage that I actually produced these slides that they weren't allowed to be called primary health networks, but they were allowed to be called PHNs, while they were sorting it all out. So I was quite politically correct. Also, I'm not very good at spelling, so chronic disease management is aimed at people who either have a terminal disease or a chronic illness, which is defined by Medicare as an illness that is likely to last more than 6 months. And for this, there are 2 aspects to get them the funding for allied health. A GP management plan, which is an agreement between the GP and the patient, and a team care arrangement, which is an agreement between the patient and 3 other providers, of which only 2 can be doctors. So for a diabetic, for instance, you might have the GP, an ophthalmologist and a podiatrist, or a dietitian, and a dietitian. It's a minimum of 3. But for people with falls, we can take the whole gamut. And what this does is when patients have both a GP management plan and a team care arrangement, they can get access to Medicare funding. And now the paperwork, without which Australia will grind to a halt. This is GP management plan for one Bilbo Baggins from Bag End, Shire. He's actually doing quite well. He's only got 2 problems, osteoporosis and idiopathic proximal myopathy of hobbits. So he's obviously at risk of falls, okay? So what we've done is I sat him down and I said, now listen, Bilbo, you've got to do some walking, and I want you to walk around the Shire twice a week. And we're going to gradually build that up to 5 times a week, okay, over the next few months. And so we get that done, and then we get the team care arrangement. Now we've got exactly the same problems and exactly the same goals, but because this is a team care arrangement, we have to involve other people, and this is what I want to do. So we get an occupational therapy referral from a Hobbiton Allied Health Services. So the OT will go out to Bag End and make sure that he's got a ramp to get through the front door and the appropriate rails and non-slip mats and stuff. I'm going to refer him to my friend, the physiotherapist, for exercise and balance classes at the Physiotherapy and Brewers Company. I don't think I have much problem getting Bilbo to go there. We're going to get him, since he mainly eats biscuits and ale, we're going to get him to see Peregrine Whalebelly, the dietitian, for discussion about improving his diet. Okay? Having done these two forms, we can then organise this, and this is the referral form that they then take to each of the provider. And this is the one that I've done for the physiotherapist, so he gets 3 visits with the physio. There's a similar one to the occupational therapist, 1 visit there, and a similar one to Mr. Whalebelly for the dietary visit, and that's his 5 for the year. But it will make it financially viable for Bilbo to go to each of these private allied health services. And that's one of the things that we do. Now, because I'm old and a dinosaur, I still do house calls, and this is where personalised care comes in. And every so often you walk into this, and you look at it and you say, you think back and you think, no, I have to be professional, I have to be person-centred, patient-centred, culturally appropriate, and you say, sweet mother of God, Doug, what were you thinking? And he says, I don't need an electrician to change a light bulb. You say, you need more than a flaming electrician to fix your hip when you fall off that lot. What did your wife say? You said, oh, Esme told me I was a blimmin' idiot. He said, do you know what, Doug? Esme's right. And that's personalised service. It's targeted, you know it's sunk in, and you know Esme's standing behind you like this. And that's not going to happen again. Okay? You hope. Yeah. But you know it's not going to happen without opposition. So, this is what we do. We know the patient over a period of time. We try to get these multifactorial changes in, and we've got mechanisms to do it, and we've got the time to do it. As I say, a lot of the time you sow the seed on the first visit. You water it a bit the next visit. And then you just fertilise it the visit after that. And if you really play your cards right, the patient thinks they've made the decision. Okay? And that gives them ownership and commitment. And the evidence is quite clear, studying many changes in behaviour, that attendance on a GP is a very, very good moderator of changes in behaviour for the better in patients. We've demonstrated it quite clearly in smoking, we've demonstrated it in exercise, asthma control. There's been many, many studies that have shown that together with the public health education, which is so vital to raise community awareness, that visits to a GP not only change behaviour, but continued visits will maintain that change in behaviour. So at the end of the day, general practice is about teamwork. And like all teamwork, sometimes you feel like you may be going backwards, which isn't that. Here we go. Everybody's got to do, I'm afraid this is a bit slow, everybody's got to do their own bit to make sure everybody else can work properly. We've all got to work together. This is the Intermediate Ladies 8 from West Australian Rowing Club, training during the winter, as you can see. And although they're going backwards, they're getting somewhere in good time. And they're all working for the better of the patient. So this is what we do. We are the generalists. We cover most things. We know the patient well. Evidence demonstrates that we're potent instigators of patient change. We can organise allied health appropriate to the patient. And that's another important thing. We can get access to Medicare funding for chronic disease management and for allied health care. We've got access to other government-funded programs, and we know what's available locally, and we can continue support into the future to maximise behavioural change. When Sue asked me to do this, she said, 30 minutes tops, with one of those steely nursing smiles. So with my years of experience, I've learned to realise, oh, right. So 20 minutes, I've got a couple of minutes for questions. Any questions? Yes?
Can I ask you a couple of questions about the team care arrangement?
Yeah.
In your setting, do you tend to send those referrals privately only?
No, not necessarily, but the reason I made the big point about only private referrals is that they can get Medicare funding. If we include a state or federally funded group in the team care arrangement, which we can do, it means we can maximise the payment, or we can transfer those 5 paid attendances to somebody else.
Because I work in the public setting, we often get referrals with the actual 5 visits just for physio on the team care arrangement to a public setting, with nothing else, no other allied health or anything involved. So in that instance, I usually just talk to the GP and say, did you know that you can send them to the private, physio is all they need?
Yeah.
Is that the right thing to do?
Yes.
And also want to ask, what's the gap that patients have to pay?
I'm not quite sure how much they get at the moment, I'm afraid. And I can't answer that because that depends on what the individual private physio charges.
Do you know what the rebate is roughly?
So,
I don't know why I've got about 53.
sounds about right, yeah.
Yeah, that was about 3 years ago.
Thank you.
Yes.
I was just wondering, there's a lot of new doctors coming from overseas, GPs. Is there a resource site or a resource book where they can learn basically what's available?
I don't know. I would have thought that the document that Nick's been working on, the broad bottom of books, should be made available to all of them. That's the aim of it, isn't it?
I mean, that certainly would be aspirational.
Yeah.
But yeah, of course, everyone would read it and go through it and stuff. I think it's a good point, and I know with the WAPA group, and I know Nick and I have been working with them for relating to education, but one of the things they're trying to develop is a thing called health pathways. Falls is not top ranking for going into health pathways, but that's the kind of current Department of Health idea for GPs. But I think, you talk, I mean, that's because I'm working with the Department of Health, but the GPs that I've spoken to are like, what are you talking about, what's that? So that's the idea, is this health pathways, which is taken from Christchurch in New Zealand and is used over east, is that program gets adapted so the primary care provider can access, look, and then it will be locally contextual to who's available, who does what. So, but there's an enormous body of work to go to get to the point where that's operationalised. So at the moment, but like there are GP documents like the Silver Book and stuff like that.
Yeah, there's essentially the Royal College of GPs produces a book called the Silver Book, which is about residential aged care. There's the Red Book, which gives advice on screening, and full screening is part of that, I understand. There are multiple, I suppose, drug company run evening presentations and such, which tend to focus on the drugs available, but virtually everybody who comes and talks about a drug, because it's usually a specialist such as Nick or a bone specialist will come and talk, and they'll always talk about exercise, balance, getting our health involved. So yeah, it's an ongoing process.
The idea of de-prescribing, is that, I know you said that's something that you do, but do you think that's something that your colleagues are generally looking at, or is there a push for that to happen at all? Because
it's one of those areas where you're sort of damned if you do and you're damned if you don't. Because there was an article in the paper a year or so ago saying something like only 60% of people are being treated to guidelines for heart disease. But if you look at heart disease on its own, if you have an acute coronary event, you will come out of hospital on a statin, aspirin, an ACE inhibitor, a beta blocker, and clopidogrel. Okay, so that's 5 tablets. And that's for your one event where you just have a bit of chest pain. And you lob it in, cardiologist says, nope, your arse, snaps it and gives you the pills and you're out. So if you've already got depression and diabetes, you're already staring down the barrel of some trouble. And so the issue is it's actually easier to add a pill or something than take them away. And elderly people tend to have multiple morbidities, as you're aware, multiple chronic diseases and multiple medications. And it takes time to reduce them. And because my population's elderly, I spend a lot of time reducing pills and trying to persuade people to reduce pills. And Chris Etherton Beer recently has done a very good, thoughtful paper on exactly that issue of reducing tablets that are supposed to be for secondary prevention, such as aspirin, clopidogrel, statins, in people who are elderly.
I mean, I've seen patients that have had 2 full Webster packs, and
Yeah.
I just think, you know, this is really necessary. And I guess, I think for GP, like quite often people that have got multiple issues and see multiple specialists, they all only look from their own perspective, and it really does need a good GP to look at the overall picture, but then often they seem to feel intimidated by all these other people that are prescribing.
Look, you've really hit the nail on the head. It's a difficult issue. In the last couple of years, Australia has moved from a situation where there are more GPs than specialists to the other way around. And the evidence from all over the world is any jurisdiction, large or small, that has more specialists than GPs has poorer health outcomes for higher costs. And I'm quite sorry about this.
No,
this is the truth.
great.
And one of the problems is that people get siloed into their specialty. And cardiologists, God bless their cotton socks, are the very worst for it. Because virtually every GP you talk to will have had a patient in the last couple of years who's turned up in their surgery with chest pain, and you sent them off to hospital saying chest pain query calls, and they log back at your desk the following day with a letter from the hospital saying chest pain query calls, not cardiac. And you think, okay, good. Where do I go from here? You guys are supposed to be the specialists. You guys are supposed to do the investigations. And to be honest, it's only the geriatricians in this town that actually do that with any degree of looking outside their specialty. And this is the other issue that we have, that people will prescribe only within their own specialty and ignore everything else that's happened. So yeah, I try to do a lot of deprescribing.
Do you utilise the home medicine review?
Yes.
Do you think other GPs do? I guess that's a hard question.
Look, I can't speak for other GPs. I actually like the home medicine reviews, and in particular, I like the residential medication management reviews, because they're very helpful, because quite often basically, I'm a great believer in second opinions, and having someone to just look at all the pills that I've written out for somebody is very helpful. And every so often I'll get the support back and think, ooh, shouldn't have done that. But the fact is, somebody else has picked it up. It's one of the great advantages of group general practice, that somebody else will see one of your patients and have a proper look at them, because you've got used to them being like that. I had a patient quite recently, hardly my proudest moment. I've been looking after her husband for a long time, as he'd been getting more and more and more weak and frail with Parkinson's disease and becoming wheelchair bound, and putting in supports for her and him. And she'd been coming in and saying, oh, I'm getting more and more tired. And I was saying, well, I'm not surprised, you've got to do a lot of heavy lifting. And shortly after her husband died, she went to see my partner, who actually listened to her heart, discovered she had critical aortic stenosis, which I had not thought of, because I was so concentrating on her husband, and because I'd been seeing her for 3 years, she'd only been getting gradually more tired. So group practices are a good thing, and we all make mistakes.
Is there a lot of paperwork involved with referring for a home medicine review, or is it quite simple?
I've just demonstrated to you what the paperwork involved in team care arrangements and GP management plans are, and I have to say, I must thank the federal government for reducing the red tape to just what I showed you. Home medication reviews are not particularly difficult as long as you know the rules, and that is that you must refer the patient to their community pharmacist But unless their community pharmacist is a registered pharmacist, they then have to refer the home medicine's review to a registered pharmacist who's registered for home medication reviews to go and do it. Is that still the case? Yeah. So if you're lucky enough that your community pharmacist is a registered pharmacist, then everything's sweet, but otherwise I'll have to hire somebody to do it.
Where can we get more information about the types of things that GPs can refer for, like the TK arrangements, supervision plans, home medication review? Like, where can we find out all the rules and procedures and...
Medicare benefits schedule, but will go half mental. Look, I'm not only a dinosaur, I'm obsessional, so I know my way around the Medicare benefits schedule, but nobody else really understands it.
Is it, can you get access to that easily, or...?
Yeah, you can access it online. With the department. And the department's got some good guidelines. If you go to the federal department Medicare site, there are some quite good guidelines about what we can do. But basically, the allied health providers that you can refer to are listed here. So Aboriginal health workers, audiology, chiropractors, diabetes educators, dietitians, osteopaths, occupational therapists, mental health workers, exercise physiologists, speech pathologists, psychologists. There's a lot that we can do to cover many aspects of many illnesses.
When you refer to private, do you consider your patient's ability to pay without that?
Yeah.
I know private practitioners have said if they see someone who comes who looks, well able to pay as a private patient without that, they kind of feel a little bit as if that's where their gap is applied more than anything.
That's up to the individual practitioner.
But you'll give that to someone who you feel medically needs to do that regardless of their ability to pay for it.
Most self-funded retirees don't have a lot of money.
Yeah, I agree with that.
Okay.
Sorry, just having worked in private practice, sometimes when you receive these forms and they've got maybe 2 visits and they've got chronic back pain or something, there's little you can do in 2 visits when they're not prepared to come back and pay a fee.
That's right. I mean, sometimes what I want people to do, and I'm aware of that, but I will often say to people when we've divided them up and they've only got a couple of physio visits, I'll say, look, you're going to see the physio a couple of times, but they're going to give you exercises to do at home. And the benefit there is I know the patient is getting exercises given by a physiotherapist, not ones they picked out of Women's Weekly. Okay? So they're not going to injure themselves.
Yeah, just
And I say to them, it's up to you. It's your work. You've got to do it. Which again is empowering the patient. Thank you.